All right, hi everyone. We'll go ahead and get started here as more folks continue to join, but welcome to Virginia Clinicians for Climate Action's 2020 webinar series, Health in Virginia's Changing Climate. We're very excited to have a great presentation today by Dr. Rebecca Philipsborn from Emory University in our best titled webinar, Belly of the Beast. We look forward to having you participate. Just so that everyone knows, all participants are in listen-only mode, and we will be accepting questions today. We'll have a Q&A session at the end of the presentation, but you should see a Q&A dialog box on your menu of the webinar on whatever platform you are using. That's how we will accept questions and where we will be answering questions from at the end of the presentation. So I encourage you to go ahead and submit those as you have questions throughout the presentation, and we'll answer as many as possible at the end. With that, I will turn it over to Dr. Samantha Dute, the Chair of Virginia Clinicians for Climate Action, for an introduction. Sam?
Good afternoon, everyone. It is my distinct pleasure to introduce our speaker today, Dr. Rebecca Philipsborn. Dr. Philipsborn is a primary care pediatrician at Children's Healthcare of Atlanta and Emory University, and she is one of the founding members of Georgia Clinicians for Climate Action. At Emory, Dr. Philipsborn is Associate Director of the Pediatrics Global Health Track. She is also a member of the Southeast Regional Pediatric Environmental Health Specialty Unit, and she is a working group member of the Lancet Countdown for Health and Climate Change US Brief. Her scholarly work focuses on climate change in medical education, as well as the impacts of climate change on global child health. Of note, she is the author of a recent outstanding article in the Journal of the Association of American Medical Colleges on incorporation of climate change education in resident education. Dr. Philipsborn completed medical school and residency training at Emory. She holds a an MPA in environmental science and policy from Columbia's Earth Institute program, and she is holds an undergraduate degree in English from Princeton. So with that, I will pass it to Dr. Philipsborn.
Thank you, Sam, for that introduction, and to John as well. And thanks for inviting me here today. It's great to be representing Georgia Clinicians for Climate Action, as I'm able to talk to our sister group. You guys have been in existence a lot longer than we have, but I'm looking forward to the discussion today. And let me get my slides shared for you. All right, I'm going to trust that Sam and John will interrupt me if there are any technical difficulties or something happens with my microphone and you can't hear me. And without further ado, we'll get started. So I've integrated a couple of poll everywhere responses into the presentation. If you've not used this before, it gives me a way to make sure you guys are still out there since I can't see you, and for you to participate as well. So kind of as a warm-up exercise to get you joined for the poll everywhere. If you can follow those instructions up at the top, I'd love to see who all is out there today. And I know that many of us fit in more than one of these categories, so feel free to use your discretion and choose the one that that represents you today. So I see our students are figuring out the technology first. Awesome. Excellent. So it looks like we have a mix of mostly practicing physicians or residents in primary care, a lot of medical students, and even more medical students, and several in the other category as well. So some learning objectives today, we're going to talk about linking changing weather patterns to altered risk of enteric infections. We're going to talk about guidance for patients on ensuring access to safe water, summarize the risk that climate change poses to food security and nutrition, and describe the health and climate mitigation benefits of plant-forward diets. So this blurb is from a piece that came out from the Georgia chapter of the American Academy of Pediatrics. And the world feels a bit crazy right now. There is a lot going on, but these discussions are more important than ever. And I think this says it well. As we confront an infectious pandemic of zoonotic origins and the persistence of racial injustice on the brink of our sweltering summer heat, this is from back in early July, and looming hurricane season, the climate resolution is more resonant than ever. Climate action is a critical component of efforts to prevent future emerging infectious illnesses and to address the structural racism and systemic inequalities that make communities more vulnerable to environmental exposures. So the framework that we use really does need to be a planetary health framework. It's more than what was traditionally used, especially around enteric infections, of One Health, which is how the health of people and animals are related to environmental health. But it really looks at those social and political underpinnings that affect health as well, that adaptation, that community factor. So how am I talking about this as a primary care pediatrician? What is my background and interest in enteric infections and gastrointestinal illnesses? Well, before I went to med school, I actually worked in public health, and I lived in West Africa in Senegal, working for the United Nations World Food Program. So this is back in 2007. I know exactly when this picture was because I was doing something touristy as opposed to my day job. It was New Year's Eve. And at the time in Senegal, I was looking at maternal and child health and nutrition for some of the most vulnerable populations along the Sahel Desert, just south of the Saharan Desert, and looking at how we can do outreach to secure the nutrition of nomadic populations there, as well as supporting country offices in West Africa on their infant and young child feeding programs. At the same time, I was able to work with graduate students from my alma mater at Columbia and looking at the first assessment of how climate change is going to affect food security and nutrition in West Africa for the World Food Program. At the time too, this link between nutrition and diarrheal diseases in the people we were serving in West Africa and children was so important. So as you guys know, nutrition makes children more susceptible to diarrheal disease, and diarrheal disease makes children more likely to have malnutrition. They are very tightly intertwined, and I think that's important for today. We're going to talk about these things together. When I finally came back to medical school, I started working with one of my mentors here, Dr. Karen Levy, and wanted to apply this experience I'd had in West Africa, looking more at infectious illnesses and climate drivers of infectious illnesses. So as a med student with Dr. Levy, we did a systematic review of diarrheagenic E. coli. So we took all the studies that we could find at that time that were published between 1975 and 2012. We wanted studies that had incidence data, like how many cases of E. coli we were seeing at least monthly for at least 12 consecutive months, so we could get all the seasons of the year in the study. And we needed them to include at least 25 confirmed cases. So we paired those data with historic climate data for the same area using NOAA data sets. So we could look at the case load of diarrhea for a specific geography and the temperature and rainfall data for that same geography at that same time. We did a meta-analysis of the association between temperature, rainfall, and disease incidence. This kind of shows some of the outputs that we did. For every single study in the analysis, we did a graph of seasonality where E. coli cases are in black, and in red at this top graph you see temperature, and in blue you see rainfall. And for the most part, there was a seasonal trend with greater incidence in warmer months. But we did notice that that's not always true. Things like altitude seem to be relevant for that assessment as well. We also found that on average across our study, every 1 degree Celsius increase in mean monthly temperature was associated with about an 8% incidence of E. coli diarrhea. And that's what's circled there in green. It was statistically significant. And if you're wondering why it says temperature no lag plus precipitation 1 month lag. What we did, the temperature only, if you don't include precipitation at all as a potential confounder, actually has an even stronger relationship. But we know that warming doesn't happen without rainfall. So we looked at precipitation as well and precipitation patterns. And because the link between diarrheal disease and precipitation takes a little while to manifest in illness, you may see runoff before you see disease in people, we use this 1 month lag. So that's kind of my background and how I approached this subject early on. These kinds of assessments allow us to start projecting out what we think the incidence will be. And so we looked at where we had the most cases was actually in Bangladesh. And we said this in the near term, in this 2035 to 2065 time frame, with what we're expected to see as far as increased temperatures, this would equate to 1.6 million additional cases of diarrhea. We did this with very broad confidence intervals, which is at 483,000 to 3 million, so really broad confidence intervals. But the lesson there is one of the most important lessons I can think of when I'm talking to students and clinicians about climate change and its impacts on health. When the baseline burden of disease is immense, like E. coli diarrhea, even a small proportional increase represents a large number of cases with really significant public health importance. Or as Dr. Levy would say, a big number multiplied by a smaller number is still a big number. So that's just a little bit about how I came into the discussion and my background on nutrition and diarrheal disease. But that's just one, E. coli diarrhea is just one cause of diarrhea. When we're thinking about diarrhea, there are all sorts of different things that cause diarrhea. So how do we consider all of them? This is just a table of some of those etiologic agents we need to consider as physicians. So Dr. Levy went back and did a more thorough review across all causes of diarrhea where she could find data, called Untangling the Impacts of Climate Change on Waterborne Disease, a systematic review of relationships between diarrheal disease, temperature, rainfall, flooding, and drought. And when she presents this, especially around the rainfall data, she likes to use this. It's complicated. Relationship status is complicated, but there are some things that emerge. So overall, there's a positive relationship between diarrhea and meteorologic conditions expected to increase with climate change. And that can be increased temperature, it can be increased drought, and it can be increased flooding. In some cases, we see drought and flooding together in the same areas at different times of the year. The exception to that is that viral diarrhea doesn't increase with increases in ambient temperature. And we kind of know that clinically, like we see our viral diarrheas later in the winter than we see our summer, more bacterial diarrheas. The confidence in these relationships range from low for the relationship between drought and all-cause diarrhea and high for the relationship between temperature and diarrhea. So just to kind of talk about these mechanisms that we are exploring a little bit more, you can think if there's a prolonged period of drought, it allows for something called the concentration hypothesis, so concentration of pathogens in water sources that then give a higher infectious load to people that may get infected. There's also this relationship with flooding seems to have the biggest impact after a period of drought, where you get this first runoff effect where more contaminated surface areas are flushing bacteria into waterways, into places where people may become infected with the bacteria. If you have a flood event after periods of heavy rain, there's more of a dilutional effect, and it seems to not be as likely to have an impact. So this is kind of like the public health framework that some of our colleagues have put together. And they've given us some clues to the mechanisms. So we know that temperature can increase the replication rates and survival of bacteria in the environment. It can affect transmission rates, the infectious dose, incubation period. All of these factors of pathogens are related to these climatic variables. It can even affect pathogen gene expression. There are some behavioral things too, like cookouts in the summer that can affect human exposure. So there are these complex relationships between the environment, the host, and pathogens that our public health colleagues have been helping us untangle. So bottom line is, for us, from the epidemiologic side, climate change is changing these patterns of infectious illnesses. We're going to have to stay aware of these changes in epidemiology and adapt our practice, adapt our differential diagnosis. But is that really helpful clinically? For those of us who practice in a clinical setting beyond the research space, what do we do with this information when we're talking about one patient and the practice of medicine in front of us? So I just recently found this review from May and June of this year in the Journal of Clinical Gastroenterology. It's the first paper I could find providing a framework for the consideration of GI disease related to climate change. This is their table where they look at the changes that we'll see because of climate change and how we should consider this for GI disease specifically. And because I know many of you are experts in this area, I didn't go back and review the changes that we're expected to see because of climate change, but I think you all know that we're expected to see warming up to almost 5 degrees Celsius without action taken. We'll see changing and intensifying patterns of rainfall, which can be drought or flooding cycles, increase in extreme weather events, and sea level rise. So these are the climate factors that we're talking about. And this is the table of our GI colleagues and what they are saying we need to be looking out for. So food security, water security issues, these increased rainfall and flooding events with this risk of infection, change in disease patterns and migration. So really kind of what we're talking about from the public health side. So in breaking it down, I think what's helpful for me is to look at cases specifically. So we're going to jump into some cases about GI illness and then move over to the nutrition side. A 7-year-old presents to your office. They have a 2-day history of fever, diarrhea, vomiting, and abdominal cramps. What questions might you want to ask this 7-year-old? And through this format for Poll Everywhere, you actually get to vote up and down each other's responses. So if people are brave enough to start, others will be able to elevate their responses. So you have the 7-year-old, diarrhea. What do you want to ask them? What kind of exposures might you screen for? What's their water source? Any recent travel? Excellent. Have they been around any sick contacts? Some more travel and slightly different words. So it looks like travel's getting the most votes. Recent diet. Excellent. So starting to get into their food history, their drinking water source, any blood in stool. Excellent. That's going to affect your workup. What about any contact with animals we might want to ask? Any recreational activities? And we're kind of assuming that we know this patient, so we probably already know their background and whether they have any immunocompromised, but that's certainly something we'd want to ask as well. So what you learn is that your patient's not had any contact with farm animals or reptiles. He's not eaten at a cookout or barbecue or had undercooked fish lately, and his family drinks filtered municipal water. When you ask about recreational exposures, though, you learn that he did visit a splash pad about 3 days prior to presentation. So what do you do next? And this is more for the practitioners out there than the med students, but feel free to posit your responses and we'll see what we get. What would your workup look like? Or would you do nothing? Reasonable answers. Hydration and observe. Maybe a stool culture. Great. So we're gonna make sure this person's not dehydrated. Check for management. There we go. And then do conservative management. Observe. And that is 100% reasonable in this framework because this is we're assuming healthy child who's only had a couple days of symptoms, and unless there's something that alarms us with their physical exam, they probably don't need further workup. This our framework for how we treat patients isn't necessarily changing because of climate change, but it's something that we are likely to see more often and need to have on top of our mind. So down here linked at the bottom is the CDC MMWR for consideration of actually foodborne illness, but I think it's a good framework for thinking about these waterborne, foodborne, climate-related diseases. So when to do more than wait. Just a reminder, if we see bloody diarrhea, weight loss, if there's dehydration, fever, prolonged diarrhea, which we're talking about several days, if there's neurologic involvement suggesting like a toxin type exposure, these are reasons that we need to start doing more. And then you would start with a stool culture. So that's a good next step if we're concerned. I also think it's important to realize that in this framework, CDC says we're their sentinels, we're their eyes and ears in the community. We may be the first people that see signs of an outbreak. So if we're concerned about an exposure that may be related to a source that could be involved in an outbreak, that's another reason to think about getting a stool culture based on that exposure history. So in this case, this patient's diarrhea was actually linked to this splash pad. This is one of my favorite studies I've encountered on this topic. So it's in environmental health, and they investigated a waterborne outbreak of salmonellosis linked to splash pads. So this, if you probably know what a splash pad is, this is one in my former neighborhood down here in Atlanta, where you see a lot of the children there are young, and they love to put their mouths on the water. They love to sit on the water. And I love the language in this article. So they say among the patrons observed, common high-risk behaviors include sitting on the fountain or spray head and putting mouth to the water. Not only that, but 21% of the patrons were wearing diapers. And among those, another 20% were seen getting their diaper changed at the splash pad. So these are all things that increase the risk of transmission of disease. So once this outbreak was identified, and this was in Tennessee, the study team did a survey of splash pads in the state and found that 1 in 5 had less than the recommended amount of chlorination, and about 17, and there was bacteria found in 17% of those samples that included E. coli, Giardia, and Salmonella. These are things that are increasing. There's going to be more likelihood as the climate warms and as people are seeking ways to cool off. So the lesson here is really thinking about those exposure risks, even recreational activities, when we're looking at patients with GI disease. What are some other risks of exposure? So this is another study actually from your region up in Maryland, and it's the first study linking this risk of living in a coastal community with increased risk of salmonellosis compared to living inland. So coastal communities are more vulnerable to flooding events, and these infections can proliferate with elevated temperature, and then that increases the bacterial transmission to surface water and food crops, and can affect the coastal communities downstream. So they did a similar approach where they looked at historical cases, because this is a reportable condition, and they looked at weather data from those same timeframes. And they found a 4.1% increase in salmonellosis risk with increase in extreme temperature. So more and more pathogens are seeing this link between increased burden of infection and temperature. This is more pronounced in coastal versus non-coastal areas. They also found an increase with extreme precipitation, and this is also more pronounced in the coastal areas. So those areas along the coast are more at risk. I want to point out the BRACE framework, and this is born from CDC, and they have these beautiful infographics that I think for folks like us, when we're part of the Clinicians for Climate Action and we're looking for ways to educate community, this is a good place to start for really clear infographics on some of these issues. So this is highlighting a BRACE project about contaminated water, and this one was done in North Carolina, and you see here very dirty water flushing out of the system. In North Carolina, there's already been 1 foot of sea level rise over the past century, and by 2100 they're expecting about 3 feet of sea level rise along the coast there. So in this project, they did a mapping of vulnerable health-related infrastructure, including water treatment plants, to try and improve the resilience of those plants and protect them when extreme weather events occur. Because without that resilience, the overflow from those plants or the breaching of those health-related infrastructure can impact communities and cause harm. So this is another way that I think it's an advocacy opportunity for us as physicians to think about ways that we can advocate for that kind of bolstering of resilience in the public health system and protect patients. So some communities that are at even a little higher risk as well are those with combined sewage systems. I got to learn a little bit about sewage systems in Virginia, and actually I'll say that on Richmond, Virginia's watershed site, there's like a fabulous video educating on combined sewage overflows and what they've done to prevent those in the area, and what you can do as a private citizen to help avoid and do your part in preventing those as well. But these combined sewage systems are ones that take both sewage and waste from homes, but also drain stormwater. That means they're going to be at much greater risk of overflowing and heavy rainfall events when both those sources are coming together and there's just a deluge of rain. So in Virginia, there are three communities that still have these combined sewage systems: Richmond, Lynchburg, and Alexandria. When we talk to patients, we have a role here as they're linked to the public health system and in making sure that they are receiving public health messages. So the public health system does already create these messages about when there's an overflow event and when the water may be unsafe for people. But to what extent does our community receive and respect that information? So this is a metric to that effect that's a part of the Disaster Resilience Scorecard for cities for the UN that I helped work on. And I think we can help boost the community's trust of public health messaging simply by discussing it and including it in our visits. So these range from there's really no attempt to convey public health information to public health advice has been shown in prior disasters to be universally received, accepted, and acted upon. Where do you think we fall right now? I know with coronavirus, I'd give us maybe like a 1. We've not been doing the best job at conveying and receiving public health information in some parts of the country. So we can play a role here. Right now, I don't think in my clinic we have this kind of infographic, and yet we know that we have boil water advisories. We know that our patients are at risk from these exposures and may not be linked up to the proper public health information. And different municipalities or counties have SMS type alert systems that they can send alerts to our patients, to us, when there are health harms. I think this is something that we can include either as a new type of infographic from our CCA, or if we don't have these in our clinics, addend it to our routine handouts that we provide patients at their visits. And we can recommend that our patients, especially those who depend on a daily dose of a medicine or who have immunodeficiencies, are prepared with what's recommended is actually a gallon of water in extreme events, a gallon of water per household member per day. We can help prepare people as these things are starting to become more common. It's always a balance when you're in clinic about how much time do we have to discuss different things, but as these exposures are becoming more common, I think that balance is tipping towards discussing these more, especially around preparedness. You may get questions in your clinic about filtration devices and what we should be recommending and how these devices work. I probably don't have time to go into all of this information today, but I have resources and references at the end, and CDC has a fabulous table that breaks down the different types of filtration and what they filter against. So I want to make you guys aware that this is out there. Another example of a BRACE framework and action was around contaminated food. And this project, again, was right up in your neck of the woods up in Maryland. So there, the Department of Environment actually partnered with the National Weather Service to provide daily shellfish advisories and provide shellfish growers with fact sheets to avoid this emerging increase in Vibrio illness, not just GI symptoms, diarrhea, vomiting, but also life-threatening skin infections when you already have a break in your skin that we're starting to see along the East Coast. So this is an example of a fact sheet from the Maryland Department of Public Health on Vibrio bacteria. So for those who may be at greater risk because of an occupational exposure like they're shellfish harvesters or they have a recreational activity, this kind of handout can be really, really helpful. To summarize this broad overview of gastrointestinal disease in our practice, I think these are kind of my takeaway points there. We need to assess our environmental exposures in our sick patients and think about climate-related exposures. Consider labs to aid in diagnosis if there are those extra sick symptoms or if an outbreak is suspected. We need to remember that these diseases are notifiable. So if we do diagnose them, we need to report them to public health authorities. That's part of our role in physicians, is recognizing climate-related disease so we can quantify the burden and really help inform our public health prevention efforts. If we don't properly diagnose these, they'll get missed and they won't get calculated in the burden of climate-driven diseases. We need to educate our at-risk and vulnerable patients about preventing exposures and creating preparedness plans. And we can access and refer patients to water alerts. Work with them right there in clinic. You can say, let's put this alert on your phone, or have wherever your county or city is, whatever you think is the most appropriate for that family, have them link those to their own phone so that if there is a disaster and it's not a time when they're right there in clinic with you, you've still given them some tool towards prevention of illness. And then I think we also have this role in advocacy around equitable infrastructure improvements, those combine sewage overflow improvements and other shoring up our public health related, either from coal ash pits to water treatment plants, against this risk of sea level rise and climate related floods. So we really are a liaison between patients and public health systems. So switching gears here, I want to talk a little bit about nutrition in our changing climate, both the risk that climate poses to nutrition and the opportunity that nutrition poses, changing nutrition poses for climate. So a full-term 3-week-old presents to the emergency room. He's not eaten in 6 hours. Parents have gone to 5 stores and cannot find formula. Exhausted, they hope the hospital has some. This is a real case from our clinic here. And this was, of course, because of the recent coronavirus pandemic when shelves were bare of formula, and some of our patients really were seeking emergency care because they could not find food. I think this gives us a preview of some of the either regional exposures or other disruptions in the food delivery system that we can expect. I'm just curious for those from students to primary care providers, who is seeing an increase in food insecurity during the pandemic? So it looks like most people say definitely yes, but some think maybe anecdotally, but not totally sure, and some don't think that they are. And I think a lot of that depends on where we practice and who we take care of. So overall, this Feeding America estimates that there may be more than 18 million children. I'm a pediatrician, so I start with children, but 54 million people total who may face hunger in the US during this year. And part of that is because of the pandemic. We are expected to see more disruptions in the food system because of climate change. And again, COVID has been a preview, both in what stores have available, what home delivery options exist. And these last 3 have been what's critical for my patients. Some of our WIC offices still aren't running. The Women's, Infants, Children's Services, some of them still aren't running at full steam. And when people depend on that for their formula, this is a real problem for them. And then our school food programs for our school-age kids, when they've been out of school, some of the schools did have distribution programs because these children depend on school for breakfast and lunch. They've been out of school now since March and do not have the same degree of food security without that safety net. So how do we bolster the food distribution system for places where our patients and our children are, how they normally receive their nutrition? As there are disruptions and actually crop losses, there's a risk that our food pricing could go more to a scarcity-based pricing, which would further exacerbate food insecurity. And there's kind of a research question here that we don't really know. What is the impact of this kind of food system disruption on the choices of food that our parents are making? We know that lots of people are grabbing more frozen options, more pastas. Are we seeing different food choices that will affect nutritional status as well? So what's our interface here? I think it's really important now, and increasingly so with climate change, to assess for food insecurity at every well visit. We need to double down on supportive breastfeeding as something that's we know is good for, it's like a win-win. We know it's good for our infants and moms, and it's something that promotes resilience as well. We need to counsel families on preparing for disasters, and then having an existing database of referral services in our area is helpful. So we have a role here in preparedness against food insecurity and food disruptions, and we can be a part of that safety net, a service for our patients that rely on that social safety net. Another case, this is one that's become really common lately, even pre-pandemic. So a healthy 18-month-old comes in for her checkup. On review of her diet, mom reports that she drinks 2 to 3 cups of milk per day. You ask what kind, and she says the breeze kind. So I used to ask about what kind of milk people drink, thinking I would get 1% or whole milk as the answer. But then I started getting the chocolate kind or strawberry kind. And so I realized that this is really important to figure out what kind of sugary additives may be in the milk as well. And then more and more lately, people are drinking non-milk milk, kind of like almond milk, which is really kind of like nut juice as opposed to milk. It's not the same thing. It has different nutritional value. But yet, dietary counseling is a part of every single well visit. And right now, there really aren't any dietary guidelines for us as clinicians that include a planetary health framework, what's good for the planet and good for children. So even last year, when this healthy beverage consumption in early childhood document came out, this consensus statement, they said it's not known whether the bioavailability of these added nutrients for like almond milk is comparable to that of their naturally occurring counterparts in cow's milk. So we're left in a bit of a lurch here with patients who are increasingly seeking these alternative type beverages, alternative to cow's milk, sometimes because of their concern about the environment. And we don't really have the best way to, we can go off the cuff, but we don't have consensus statements to say this is what we need to be doing. And yet the benefits of plant-forward diets for the planet, but also for prevention of chronic disease in our patients are well established. This is a place where I think we'll see change in the coming years about how we can counsel patients about plant-forward diets. Why is this so important? Well, if you look at emissions by sector, the yellowish section is agriculture, and agriculture is a huge proportion of our emissions, this contribution to greenhouse gas emissions and the climate change problem. Looks like my computer is frozen. Give me a second. I'll give you, let's see. There we go. So this next slide breaks it down by food sector. And you see that red meat and dairy are the biggest contributors overall across some of these same causes, from habitat loss, monoculture, having only one crop, pesticide use, invasive species, and of course, climate change. Our global crops depend on pollinators. So in last year's Lancet report, prolonged disruptions and droughts in foods threaten yields of all the 4 major crops that were tracked, which were rice, soybeans, wheat, and maize. So we're in this period known as a 6th mass extinction, where we are losing biodiversity. This is incredibly important for our pollinators and for our food systems, when 40% of insects are threatened. So we have a call to action now, and this is a source that I recommend all of you check out. It's the Eat Lancet Commission on Planetary Diets. And they say transformation to healthy diets by 2050 will require substantial dietary shifts. Global consumption of fruits, nuts, vegetables, and legumes will have to double, and consumption of foods such as red meat and sugar will have to be reduced by more than 50%. A diet rich in plant-based foods and with fewer animal sources foods confers both improved health and environmental benefits. So we're getting this call to action for this framework. So what you may have heard the term flexitarian. I've had patients ask me about flexitarian. What is flexitarian? So it's largely plant-based, but can optionally include modest amounts of fish, meat, and dairy foods. And it can be delicious and beautiful. All of these things look way nicer and more gourmet than what goes on in my house on a daily basis. They look absolutely beautiful. How close are we to what's a planetary diet? So in each of these charts, think of it almost like what we do for my plate. But the 100% circle is the health boundary, what would be healthy for each of these types of foods. And then on the left side of the screen, you see globally where we are, where we're consuming far too much red meat from cows and starches. And then you can see over on the right side is the North American diet, where the scale is different. So on the left side, it's 288% of the recommended value of red meat. And for North America, we're at 638% of the recommended value for red meat. And I think these are really helpful graphics to show where we could go for diets that are better for the planet and respect those planetary bounds, but also better for us and our patients as well. So we can start thinking about our dietary counseling in this framework of climate change. What I try and do now is meet patients where they are. I ask patients what their diet is like and see where they are already. If they're already trying to be more vegetarian, that's a very different conversation than someone who has not thought of it at all and maybe is eating almost exclusively fast food. So you have to kind of use our clinical judgment to fit this into the conversation. I think it's also important to update guidelines with what we know. So right now, Bright Futures periodicity schedule, Bright Futures is what American Academy of Pediatrics uses to dictate what we talk about at well visits, is open for comment. And one of the things that is currently recommended is to screen vegetarian children for iron deficiency anemia. In actuality, consumption of dairy milk has a stronger association with iron deficiency and anemia. And we know that from practice. Kids who drink 5 cups of whole milk a day are going to be the ones that are at risk for iron deficiency anemia compared to a balanced plant protein heavy vegetarian diet. It kind of depends on it's more nuanced. It's what that vegetarian diet includes that determines whether children need screening for it, I think. And we have some good evidence to that effect. And it's probably time to think about those guidelines. Does it really send the message that we want if we say, it's good, maybe it's okay, you're vegetarian, but we're going to have to draw your blood today and check for iron deficiency if you are. I think there's room to reconsider that, but to make sure that physicians are equipped with training to assess diets or partner with nutritionists around what that intake actually looks like. And then when we have these guidelines, we can mirror them in the places where children get food from WIC programs, school foods, etc. There are programs like in Georgia where our food stamps, we get double bucks for supporting local farmers markets, and it improves access to fresh fruits and vegetables. There's also this opportunity of economies of scale in our hospital purchasing programs. So what about us in our own lives? What are some things that we can do in our own lives? Well, we can think about our own diets, and I'm trying to limit this. Normally I have a more broader consideration of what we can do in our own lives, taking stock of our energy, transportation, and food sources and choices. But right now I think we're talking just about from the GI side. So thinking about our own diets, thinking about runoff and where that's a problem. This picture shows a rain garden and how we can do our part to help avoid runoff and reduce. It actually makes a huge difference to reduce the impermeable concrete type pavement and change. You may see some driveways that include gravel in them, or to have rain gardens in your home to capture some runoff to keep it from going into waterways. Rain barrels can achieve the same thing. And just thinking about our water use, especially in periods of heavy rain like we were having in Georgia today, it may not be the best time to be doing laundry because you're just adding to the water that the system is having to hold. And of course, always, always, we can vote. So in summary, these concepts, adequate nutrition and GI health, are linked. There's the strongest relationship when we're looking at all-cause GI infections between increased temperatures and infection. And the exception there is viral gastroenteritis. Overall, we're seeing climate-driven increases in these GI infections, water insecurity and waterborne disease outbreaks, and food insecurity. We can help guide our patients by linking them to alerts that exist, by having more of these water safety, food safety type infographics that we can distribute at our well visits so that they're prepared when they need them. And then water stewardship and planetary diets are part of the solution. And with our ability to counsel patients on diet at every visit, we have a role to play there as well. I know this is a really, really fast overview of an incredibly large topic, and there are a lot of, I have not been able to see the chat as we go along, so we're going to get to questions in just a second. If I can do a post-test for there, I have 3 questions for a post-test, and then I'm going to turn it over to John to start the Q&A. So for the study in Maryland, it looks like we're getting towards the 85%. So for the study in Maryland, it was that extreme heat that has the strongest association as opposed to dry periods. They actually found that the flooding and the rainfall was associated as well, but the extreme heat had that strong association in Maryland. Perfect, so this one may not move. There really isn't guidance to screen all vegetarians for micronutrient deficiencies at visits. Now, if you have vegetarians whose diet is not wholesome and including the micronutrients they need, then that would be important. But just blanket screening is probably not what we should be doing. And if anyone paid attention to the Gates note, if cows were a country, they would rank blank in greenhouse gas emissions. Oh man, I didn't emphasize this one as much as I should have. So they're not quite first. they're not releasing that much methane gas into the universe, but they would rank 3rd in greenhouse gas emissions. These are the references that I use, including those fact sheets that I think it would be wonderful to see the Clinicians for Climate Action further develop for our own geographic area. And I can share these afterwards so you don't have to kind of get them all down now. I'm happy to share them with Sam afterwards. And John, that's it. I'm going to stop my share and turn it back over to you.
John, this is Sam. We can't hear you at the moment.
Oh, can you hear me now?
Yes,
Sam?
that's it. Yep, we can hear you now.
Sorry, I was muted on 2 places. Sorry about that. Everyone, we've got a couple of quick action opportunities to highlight. One is that VCCA has a call to action for health professionals on climate, health, and equity on our website. It's on the homepage of our website, but you can have a direct link to it here. Also wanted to highlight that our parent organization, the Medical Society Consortium for Climate and Health, has a host of election-related resources, questions for candidates, op-ed guidance to encourage that climate and health be an issue as people go to the voting booth or mail in their ballots or have opportunities to engage with candidates. And we continue to provide action opportunities on our website and through our newsletter. If you're not signed up, please do so at virginiaclinicians.org. There's a Join tab. Lastly, before we open it up for Q&A, just want to highlight that this webinar is eligible for CME credits through Inova. Everyone who attended will be receiving a follow-up email tomorrow with detailed instructions. They're also contained on the webinar page on our website if you're interested in claiming CME credit for attending today. And lastly, just a reminder that we're accepting Q&A through the box, through the Q&A box, not the chat box. If you have the ability to, if you've populated the chat with any questions, if you could move them over to the Q&A, that's where we'll have a few minutes here for Dr. Philipsborn to answer questions related to the presentation. I should also point out that we have a large number of medical students attending today, and we're going to have an extended Q&A session for them. It's entirely optional. You can feel free to leave at any point during the Q&A if you have other commitments, but we'll invite all of those who are interested in joining us for an extended Q&A through 2 o'clock today if you are interested and able. But I'll turn it over to Rebecca to start addressing some of the questions in the Q&A box.
Yes, thank you again, John. And I apologize to those who were using the chat function as we went out. I actually couldn't see it while I was presenting, so it sounds like the polling was not all the way clear. And Andrew had asked me to repeat the vignette. I'm sorry I didn't see that before, but I'm happy to share it afterwards. And then I was aware I had my screen froze, but it sounds like for some people the audio was unstable before that, which I apologize. I hope that wasn't too disruptive, and thanks for hanging in there with me. It's great to see some familiar names pop up. So from the Q&A box, I see a question from Perry Sheffield. Hi, Perry. And it says, what kind of advice do I have about balancing the increased risk of GI illness from sources that are the treatment, like the splash pad for reducing heat exposure, like those really refreshing looking splash pads on a hot day, and they do look refreshing, and we've been missing them this summer during the pandemic. What this study ended up recommending was that these splash pads follow chlorination rules like pools use to prevent that risk of having contamination with these bacterial substances. I think that's probably going to be a more realistic approach than recommending that their patrons, as they call them, these in some cases infants and very young children, not sit on the nozzles or get their diaper changed. Obviously that's not up to them, and I've not seen a splash pad with every child with their mouth closed ever. So I think that the chlorination is probably going to be a better way to prevent that, and to make sure that there's some process in place for monitoring that, and realizing it is a risk if there is a lapse is what we can do there. And then John was on mute from Holman. We got that one fixed. Easiest question. Thank you, Holman, for that one. And then Jerry Paulson. Hi, Jerry. It's so great to see folks here. And Jerry is asking, does increased CO2 mean that food plants will grow more? That's a great question. So plants use CO2 for food, and there is an association between increased CO2 in the atmosphere and some plants growing faster. We know this in the medical profession because plants growing faster also means that we're seeing more pollen. So plants like ragweed, these allergenic plants, are producing more pollen because of more CO2 in the atmosphere, and we have a prolonged growing season for these allergenic plants. Increased CO2 linking to more food so far on a global scale doesn't seem like it, and it's because partly that increased CO2 is also increasing these extreme events from drought to flooding that is wiping out complete crops for farmers, and we saw that in the Midwest this past year. So that when the Lancet Countdown looked at this, they're actually finding that crops are being disrupted because of these climate effects, as opposed to having this potential for more productivity because of the CO2 rich environment. And it is also worth, I didn't really have time to go into this, but some plants, some crops produce less micronutrients in a CO2 rich environment. Even though they may grow faster, there's less of these core micronutrients like zinc and iron in some key food crops. So that's something that we'll have to keep an eye on as well. And this is a big deal for a state like Georgia, where agriculture is the predominant part of our economy. We may not be able to grow peaches here. Like, what is Georgia without our Georgia peaches in the coming years? This association between agricultural productivity and these extreme events from climate changes is really real. We saw in Hurricane Michael just a wipeout of these old pecan trees and pecan farming. You can't just kind of make those come back overnight. It takes a long time for pecan groves to grow. So farmers are really feeling this. Does the Eat Lancet Commission discuss organic foods? Great question. I'm not sure if I think that the reference I referred you to focuses on these planetary guidelines. The commission as itself probably does have some consideration of organic foods, but I'm less familiar with that. And then another question is, are there any good resources for families or ourselves for plant-based foods? I think for us, I would start with that Eat Lancet Commission and start there as a way to educate ourselves. This is something I'm really interested in, is how as pediatricians we can find better guidance for families who are kind of like ahead of us actually in trying to do this, because right now that guidance it doesn't quite match with what we're recommending through our WIC programs and through our school food programs and through these organizations. And then I have a question from Ethan Sewell. How would you recommend medical students incorporate, I think, lessons? Either less one or lessons. So we're going to go with lessons on climate effects into our medical education. This is a great question and something that I also work on here at Emory with my medical students who are outstanding and who really help are helping to advance this cause of climate change in medical education. So I don't know which school you go to, Ethan, but I think the first step is finding a faculty member at your home institution, because that partnership can be really productive in moving the conversation forward and getting aspects of climate change into the curriculum. Even without formal content in your curriculum, though, doing things like this and training yourself, I think, are going to help you be a better doctor as you move forward. And I know that John wanted to hold these questions for afterwards. So I don't know if we're ready to, are we ready to open it up, John, for the extended Q&A?